Okay, so I'm recording on my end, and just to start out with, do we have any questions about anything we covered in the last couple of sections? Let's see anything on the sticky board. Anything from the peanut gallery? He's having technical difficulties. He's trying to log on now. No problem, no problem. Just wanted to try to give people like a minute or two before get into it for real. And I uploaded the review. I would recommend not jumping ahead because the answers are highlighted. So I want to make sure you guys give yourself a chance to try to answer it. And I even have a special treat for you towards the end here. I'm actually going to give you a study that I used on the exam itself. I want to even let you look at it beforehand. It's something I've never done before. It's extremely controversial, but I said, you know what, I'm going to try it. Try it out and see how it goes. This is even better than my bogus free points that I usually give out. So, better than just a C. Just you wait, I'll show you. All right, well, just in the interest of time, I guess I'll go ahead and start going here. That's okay. And it'll be recorded so I can post it up in case anyone has any issues or anything like that. But I got 55, so that's pretty good. Just got a couple of group viewers there. All right, well, and again, feel free to interrupt me at any point. That's no problem. So this is the review prior to our exam on Monday. So the test is all written up and it looks pretty good, I think. It'll be similar in terms of the first one, whereas there'll be some definitions on there, but a lot of it will be being able to kind of like read through a vignette and sort of interpret things to see, what kind of takeaways can you take from certain types of questions and things like that. So since Kahoot is not great about the character count that it will allow, that's why I go ahead and opt for using a PowerPoint, just so that way I can kind of give you questions that seem more similar to what you'll have on the exam itself here. So without further ado, let's go ahead and start reviewing our stuff here. So incident and prevalence was certainly something that I wanted to highlight again for you all to make sure that you have a good kind of conceptual understanding of that, right? And so the different kind of concepts we talked about. So for instance, if I said something like point prevalence, you should be able to point out that, okay, yes, it is at a very specific point in time. What is the number of people who have the disease right now, right? Versus if I'm talking about incidence, that is typically the number of new cases over a period of time, so say like a year or something like that. You could also have period prevalence, which is sort of the same kind of a combination of the two, almost, where you have the initial people who have the disease at the beginning of a time period, and then you look for new incident cases over that defined time period as well. So if I wanted to look over a 6-month period prevalence would include all the people at the very beginning who had the disease plus new people who ended up getting it during that time point. So, but remember, if you're looking at incidence, it doesn't include people that like already had the disease prior to you starting that time period. So a little bit of distinction there. And if you recall, when we were talking about this graph here, where they were looking at HIV cases, remember that the incidence, and again, they were looking at 1992 specifically at the end of that year, is basically all those white bars added up, right? Because those are the bars of people who were diagnosed during these various years that were still alive at the end of the study period versus if you wanted to look at something like cumulative incidence over between 1981 to 92, you could just add up all those bars together and you have the cumulative number of incident cases during that time frame. So just different ways to be able to sort of slice and dice the data to see how you want to specifically talk about it, right? So getting into the first question here, looking at that beings model that we talked about. Remember, those are sort of the different pathophysiologic processes that go into causing disease or some sort of pathophysiology here. So what is sort of, why is this model useful for us? Like, why is this a good paradigm to use when looking at epidemiologic issues, right? Does it help us assess for like herd immunity? Does it help us determine the role of social policy? Are we evaluating etiologic factors in disease? Are we helping to allocate resources effectively? Well, just like I kind of was already talking about, because I have a tendency to run my mouth, you guys probably know about that already. Right, this is evaluating those etiological factors in disease, right? So whether it's a biological issue, whether it's a social issue, a behavioral issue, remember all the different factors that go into that, and be able to sort of look at a case and be able to determine which one of those components that it is referring to, right? So for instance, if I talk about something like smoking, that's more of a behavioral sort of factor, because that's a behavior that someone chooses, at least initially, to participate in, versus if it's something to where it's like a religious practice, that is going to be more in like the social slash spiritual sort of standpoint. So be able to kind of identify that based off of the actual the etiological factor, how it relates to the disease, and you kind of figure that out a little bit, right? Again, feel free to interrupt me at any point. I will have descriptions in here after the fact, so you can go back and review that. But again, I'll be talking about them kind of as I go along, so I don't want to spend all my time just kind of reiterating the same points over and over again by any means. So how do we define the number of new cases over a defined study period divided by the mid-period population at risk? How would we define that, right? Because remember, we talked about the differences in risks and rates, but if we're looking at the number of new cases divided by that mid-period population, again, that should kind of clue you into something right there, that being in the denominator, that's our incidence rate, right? If you wanted just to look at pure incidence, your denominator at that point would be the entire population that you're interested in, whether it be population at a nursing home or in the US, wherever the case may be. But again, remember the benefit of using a rate versus just a pure risk. It helps you with that, what we call that force of mortality, because it kind of tells us whether a lot of the incident cases are happening sort of at the beginning, towards the end, is it sort of steady throughout? And remember how that changed that mid-period population and how that affected the rate, because your denominator is changing, right? So if my denominator is very small because most of my people ended up being counted as incident cases right at the beginning, then that's going to cause that rate to be much higher than it would be if everything sort of happened at the end there. So that's one of those things you'll see when discussing rates and how they may be sometimes more useful than risk, depending on the situation, right? Okay, so how about the observed total deaths in a population divided by the expected deaths in that population, multiply by 100? What would we consider that definition to be there? So the total observed deaths we saw there divided by what we expected to see, right? We would consider that to be our standardized mortality ratio, right? And so again, why is it standardized? Well, because we're multiplying it by 100, so that sort of gives us an idea of, again, how many extra people or maybe fewer people are dying during that time frame. And so that sort of helps us to change it from a percentage over into an actual number of people, for instance, that are being affected by that. And so again, try to figure out, okay, what's my numerator, what's my denominator, and again, why am I multiplying by that constant factor? And again, it helps us to get out of that fraction and get whole numbers at that point there. Okay, how about the proportion of individuals with a given condition who die of that condition? What would we consider that to be? And again, I could torture you all and wait for someone to try to answer, but I don't think you guys want that necessary. Case fatality ratio, that's a good thought. Let's see what we think. It's a case fatality ratio, absolutely. Remember how you could divvy up that pie a couple of different ways, right? So, you start out with, you have the general population of a group, and then you have the number of people who are exposed, right? So not everyone in the population gets exposed to something, but then you have some subset that is. And then not everyone who gets exposed gets the disease in question, right? So when you talk about things like attack rate, that's when you start to talk about the number of people who actually are exposed and then get infected. And then some people remain asymptomatic, but some subset of those will who are infected will become ill, and then some degree of those who become ill will die. And so that's where we start to get into those case fatality ratios, talking about that. And again, that comes up all the time, like when we're talking about with COVID, where, looking at case fatality ratios or something like that versus the flu, you can compare and contrast, somewhat similar disease states to see, well, how does this really stack up? Is it really that much more worse, or is it better? Is more apples to apples sort of comparisons at that point. Okay. How about the number of live births divided by the mid-period population? What do we think? No one has any idea. Crude birth ratio, crude birth rate. Let's see what we think here. Right, it's a crude birth rate, right? So again, a couple of things are, why is it rate? Well, because it's that mid-period population. So that makes sense from that standpoint. And then why is it crude? Well, because we haven't really standardized it to anything. We haven't really done anything like taken into account, location, gender, or I guess not gender necessarily, but like, ethnicity, age of the mother, things like that you could do to try to standardize those sorts of numbers. So because it's crude, it can be misleading when you start to compare it to other people, right? The other thing too is that this isn't really a great rate in general, but it's one that you still will see used pretty commonly, because again, when you're typically talking about rates, the people in the denominator truly need to be at risk for the condition, right? So for instance, people getting, so I'm trying to think of a good example, people who get prostate cancer, if you're in your denominator, everyone in the US, well, that doesn't really make sense because not everyone in the US has a prostate in order to get cancer there, right? Just like in this case here, not every single person in the US is necessarily of childbearing potential, right? So, could you get closer perhaps if you use just women? Yeah, but then not all women are at risk for that, because you have people at extremes of age, people who've had hysterectomies, etc. So when you're looking at rates, you want to make sure that they're valid, that the denominator is truly those people who tend to be at risk or are at risk for the condition. Okay, so this provides the death rate within a defined age range. What do we think with that? It's an age-specific death rate at that period, right? And again, what was the benefit of using an age-specific death rate? Well, it was handy because it allowed us, again, to get better sort of comparisons between different groups of individuals, right? Because generally speaking, if you want to look at the health of a country, you look at things like lifespan, you look at the, their death rates, you look at birth rates and things like that, and typically that gives you some kind of clue. But just like in the example we looked at, they were comparing, I think it was Ecuador versus Switzerland. You found that it looked like, just with looking at the crude death rates, it looked like Ecuador was doing a lot better off than Switzerland, but it didn't take into account that Switzerland had a much older population, because maybe they had better access to healthcare and things like that. Also, birth rates are quite different between the populations. So by looking at age-specific death rates, it helps to sort of equate those things out, where you can actually figure out, well, what were the number of people, what were the proportion of people who were in that older age group between countries. Maybe it was like 30% in Switzerland, but only like, 20% in Ecuador. And what effects might that have there? And then remember, when we switched from, say, just age specific ones over to more standardized ones, that was another really helpful thing that we did, where you actually then take the proportions of people in each of these different age groups, and then you could compare them to sort of a hypothetical population. And then by comparing how each of those two countries in this case would perform in that hypothetical population, that could give you an idea of a better comparison of the death rates between the two groups, if that makes sense. Again, if anything's not making sense, just let me know. I can go into more detail on that. So again, it just helps us to make better comparisons between whatever groups we're interested in looking at. Okay, so let's go into more of a case-based scenario here. Let's say a politician is throwing a luncheon. I'm sorry, I got into the politics thing, but I'll try to keep it apolitical. But let's just say we're having a luncheon that a politician is throwing, or he's trying to get some monies for perhaps as the next election, right? And so they have all kinds of seafood they're serving there, including a quite exquisite salmon mousse. And then within 24 hours, they find that 11 of 17 of the people eating there experience abdominal pain, vomiting, and diarrhea. Okay. Of the 11 symptomatic people, 4 had fever and 7 did not. 5 had an elevated white blood cell count, 6 did not. 6 ate a shrimp bisque and 5 did not. And then 9 ate the salmon mousse and 2 did not. One of them actually ends up going on to surgery. I don't think you could eat salmon mousse as a dessert, but maybe Peter would know. He's our resident chef, correct? There you go. I always thought it was
Yeah, I'm
crackers.
not sure I know what that is really,
Oh,
but
really? I thought it was like a fancy, like a bougie thing that rich people
yeah,
eat.
think you like put it on a cracker or something, right? It's like got a lot
Okay.
of butter in it.
Yeah, something like that. But regardless, let's say we had one of these patrons actually end up going to surgery. They had such bad abdominal pain, went to surgery, and they found out it was due to an impacted stone that they had there. And so then the patient went to surgery and then ended up recovering some number of days later. They found out about 11 of the people who were symptomatic, 10 recovered, the exception being the guy that went to surgery, right? So, based off all that information there, off the case described, would we consider this to be a coincidence until proven otherwise? Would we consider this a disease outbreak? Could you say it's attributable to a bacterial infection? Is it not an outbreak because the usual pattern of disease is unknown, or should it be investigated by the CDC? Gastro bistro nonsense. Yeah, it's probably a pretty good name. Would you like the gastrointestinal pub? Would that be like a good name for a place? Perhaps. So, looking at this, okay, so someone, Matt said C, but let's look at this. So, why would we consider this a disease outbreak? Just looking at this case here, why do we think that? So, like, if you go out to like a fancy dinner, do you expect to end up with some number of those people developing severe abdominal pain and vomiting and fever? Yeah, so it seems like it's pretty odd that you would end up having that sort of occurrence there. So could it be a coincidence? Possibly, but because of the location, the timing, and all of that, yeah, it probably depends on the restaurant. I guess if you go to like, if you're looking at like gas station sushi or something, maybe your incidence would be a little bit higher. But looking at this, you would probably not expect a lot of people to develop these sorts of symptoms, white counts and fevers and all sort of stuff, right? So because of that, we could probably say it's a disease outbreak. We could do an investigation, see maybe it was a coincidence. Who knows? But again, it's one of those things where you don't necessarily want to assume that when you have this many people being affected, this percentage. Now, why could we not necessarily attribute it to a bacterial infection? Could be viral. Could it be that someone had spiked the salmon mousse with arsenic in a bid to knock off some politicians? Perhaps, right? So, there's all kinds of things that it could be. It's you don't want to necessarily paint yourself into a box and say, oh yeah, it's definitely bacterial, right? It's just like when I'm dealing with consults on the phone. I'm actually on call tonight, and I have ER docs to say, well, this patient's going crazy, blood pressure's up, heart rate's up, but the urine drug screen is positive for benzo, so how do we treat the benzo overdose? I'm just like, the guy's obviously not being affected by a benzo right now. They're going crazy and pulling at their restraints. Like, no, let's not paint ourselves into a box just because you may lean towards one direction or another. But it could be bacterial. We just don't know at this point. So in this case here, it is not an outbreak because the usual pattern of disease is unknown. Doesn't necessarily apply to this sort of situation because, there are certain situations where any occurrence of disease would be considered to be sort of abnormal. So in a case like this, where you wouldn't expect anyone to develop symptoms like this, you probably want to check it out to see what's going on versus if it's something that is more endemic. So, for instance, when we had like a hepatitis A outbreak a couple of years ago here in Florida, you could look at the normal cases of hepatitis A and then see if what we're experiencing now is above that. That could again give you an idea if it's more of an outbreak sort of situation. But here we don't necessarily need to know what the disease pattern is. It's more for diseases that tend to be endemic in a population. And then when would you involve the CDC? Like, when do you think that should happen? The CDC have like a bat phone in their office and they just pick it up and it says, come investigate? More numbers involved? Across the state lines. Yeah, so really the big thing. So if there is implications for interstate people being affected between states, then that's when you need to consider CDC getting involved because it's a federal organization, right? Versus if it's within the state, then typically it's more health departments that are dealing with that sort of thing. So just like when I was at the poison center on the phones, if we would get calls in and people thought that they had food poisoning from a restaurant, we would automatically like fill out a report and then send that to the Department of Health because they then did the investigation on that stuff. They could look to see, was there a pattern of cases? Was it related? They would do something very similar to this where they could actually investigate to see, well, who ate what? Is there some kind of link here, etc. So there's either that or you could have departments of health that could request assistance from the CDC, right? So for instance, if they think that it could go interstate, if it's something that is quite rare, if we had a case of Ebola here in Florida, I'm pretty sure the CDC would want to get involved just because of the kind of implications of that, right? Okay, so continuing on, so it says the disease outbreak, and again, you can kind of go back and read through that. It says roughly the same thing we talked about. Now, in this case here, what would we consider to be the attack rate? I kind of mentioned that before. Right, so the number of people who were at risk for being, or could have been exposed, and then the number of people that become symptomatic based off of that, right? So 11 out of 17 would be correct here because, again, 17 is kind of your denominator of people who were at risk for exposure to whatever it could be, and then 11 people were the actual ones that ended up getting the disease itself, whatever this disease may be, right? So you can go back and look at that. And again, this tells us roughly, a higher attack rate obviously means it is something that is probably more virulent, able to spread more easily, things like that, versus if it had a relatively low attack rate, right? Okay, so what's our early priority for something during an investigation like this? Should we go ahead and just close the kitchen temporarily? Do we need to define a case? Should we do a case control study, perform stool tests, or submit food samples to the laboratory? What do you think we need to do? I like the confidence there. B? Could be. So in this case here, we probably want to go ahead and define a case first, right? You don't necessarily want to jump to conclusions and say, well, let's go ahead and shut the whole kitchen down, right? Because again, if it's a single restaurant, maybe that's not a big deal. But what if it's serving like a large number of people? What if it was something like a college campus cafeteria where you have like hundreds of people that may be eating there, for instance? So you want to define a case first and say, okay, well, how do we consider people to be included in our definition? You don't need to have a definitive diagnosis at this point, but you at least want to say, okay, well, people who ate at this restaurant who, and not necessarily based off food just yet, but they developed these symptoms: nausea, vomiting, they had a white count, they had fever, whatever the case may be. So that way you can at least focus your investigation a little bit more, focus it more so than just looking at every single possibility that's out there. And so that's very important to do early on. And again, case definition evolves over time. If you realize that something else is there, like for instance, like maybe they have a SED rate that goes up or something like that, something that you can involve in that as well to get a better definition of that case. That's actually something that I want to look at a little bit when I show you that study that I pulled one of our test questions from, as we'll see just a little bit. So don't let me forget about that, okay? Now, again, performing case control studies, that could be something you do down the road, especially because, again, this is something where people have already been exposed to it. So you can look retrospectively. You can look at the people who became symptomatic versus those that didn't, and then look to see what kind of risk factors were there, right? And then as time goes on, you may consider doing things like stool samples or sending food samples to a laboratory, etc. Again, maybe the kitchen will get closed temporarily, but defining a case, I think, is probably the first thing you want to do there. Okay. All right, so the best case definition for the guest disease here would be they had abdominal pain, vomiting, diarrhea within 24 hours of the luncheon. They had acute viral gastroenteritis. They had staphylococcal food poisoning, the onset of abdominal pain and fever after the state luncheon, or vomiting, diarrhea, and an elevated white cell count. What do we think? I think A. Lots of A's. Let's see what we think here. Yes, right. So again, you want to keep it to where it is not so broad that everyone gets included. You don't want it to be so narrow that you exclude some people who might actually have the disease in question here, right? Obviously, things like B and C, we can't say by any means because we don't have an established definition yet. We're just kind of going off what symptoms we're seeing there. And again, not everyone had a white cell count. If those people had it beforehand or not, things like that. John's saying, do you want us to memorize the upcoming case study, or will the pertinent text be on the exam? I will show you exactly what I mean when I get to it. Don't fret about that. I'm not going to have you memorize a whole study just to answer one test question. Don't worry. We'll get there. Right. So again, this is probably a good case definition, not too broad, not too narrow. It's going to get the people that you're looking for. And again, this goes into things like sensitivity and specificity and seeing like, okay, well, how are we ruling these diseases in? How are we ruling them out? Remember, spin and snout, right? Remember, you want really sensitive tests to be able to rule things out initially, right? So again, it's okay if you have a lot of false positives, early on, but then as you get more and more specific tests, that's when you can start to roll those things in. So it's okay to have, tests early, where like nausea, vomiting. Well, that's pretty non-specific, right? So again, you're going to have a lot of false positives that get included in there, but that's okay early on, because then as you go on, then you can get more specific tests to actually rule in the real disease in question there. But if you had someone that ate at this luncheon and they didn't have nausea, no vomiting, no diarrhea, right? Then they're probably not going to be considered to be part of that case, because again, when you have very sensitive tests, yeah, you have a lot of false positives, but your false negatives are actually pretty low, right? So the false negative error rate is low for really sensitive tests. So make sure you understand how all of that sort of plays together. Okay, so let's suspect that the disease is a result of a common source exposure instead of what we mentioned before, like a propagated exposure, but it involves contaminated food. The investigators attempt to determine which food is responsible. So the initial task here would be to analyze food specimens. Should we close the kitchen, examine the food preparers, interview symptomatic guests to find out what they ate, or perform a case control study? What do we think? I'm going to interview them. Like, where were you July 14th? Had my hand in the trash and then I made the salmon mousse. So the biggest thing to do, I think, initially is probably going to be to interview the symptomatic guest, right? Like, do you yeah, try the salmon mousse yourself to see if you get sick as well? I'll let you do that, Kyle. So in this case here, yeah, you want to find out like what the people ate, what they didn't eat, especially when you're comparing your symptomatic patients who are included as cases versus those that aren't. That allows you to start to develop that sort of case control sort of study that you could do in that situation there, right? So you got to get the information first, gather that, and then you can do something like the case control study. Now, in cases like this, it's not usually that the entire kitchen is contaminated. It could be like if you had a common source was a food preparer who happened to be sick and they were contaminating food, but it's probably not necessarily that. It's probably like an individual food item. So, again, is down the road, is it necessary to analyze food specimens? Perhaps. Do you need to examine the food preparers? Perhaps. But again, initially, this is what you want to do to try to isolate what food it was. And if you find that it's like all the foods that were contaminated, then that leads you down a different road than if it was just one of them, right? Okay. So then, so kind of moving on from that, let's say a screening program analog. So we're doing a screening program. We're evaluating for, say, new incident case of disease. What's an analog to the late look bias? Is it length bias because the cases lasting longer are more apt to be detected? Recall bias because only severe illness is recalled? Selection bias because the program selects out asymptomatic illness? Selection bias because the program selects out severe cases? Or spectrum bias because cases are clustered at one end of the disease spectrum? I think A. What do we think? In a couple of days, let's see what the answer is. I forgot to take off. I meant to remove the spectrum bias. We didn't really talk about that too much. I can mention that later if you want. Yeah, this is going to be more of a length bias thing here. So remember, when you're doing a screening program and you're looking for like new incident cases or something, kind of like as an ongoing program, that late look bias means that basically if people have severe disease and they end up dying, then they don't get included in that screening because they already died off, right? Or if they recover very quickly, then also they're not going to be included in that screening because they don't have the disease anymore. So in that case, there we call that a late look bias. On the other hand, though, if you were doing like a typical like survey study, like more like a cross-sectional study, this has to do with that length bias as well, where people who happen to be have the disease for longer are probably going to be more likely to be detected. Because again, if they recover or they die, then they can't be there in a sort of cross-sectional study to actually be found. That's where it case there, and that could apply to like an ecological study, cross-sectional, whatever the case may be there. In terms of like recall bias, again, when you're doing a screening program, you're looking for people that have the disease right now. And so recall bias isn't really an issue because if they've already forgotten about it, then they obviously don't have it now. So they probably not going to be an issue there. And then remember, selection bias is going to be more of an issue of, when patients get sent to specific groups in a study, especially when they're able to choose which group they go to. That's when you run into some issues there. recall is bad for case control studies. That is correct, right? Because that's more so to do with like risk factors and things. Because remember, case control studies, you already know who had the disease and who doesn't. You're going back and looking in time to see who has specific risk factors. And so in this case, in that kind of case there, if they forget like, oh yeah, I forgot that I had exposure to asbestos when I was working construction for 20 years ago or something, that could be something like that where the recall bias would be more of an issue there for sure. Or any kind of like survey for like long-standing things like, well, when did your atherosclerosis start? Well, you can't really know that, right? So that can be an issue of detection bias as well. Okay. And again, just remember screening programs are typically like a prospective sort of thing, especially like with active surveillance, versus if it's more of like a cross-sectional study or something where you're trying to figure out past information, basically. Okay, so let's say we conduct a study to determine the effects of drinking Mountain Dew on a teenager's willingness to bungee jump from frightful heights. Let's say we have 500 teenagers that we've assembled on the basis of their bungee jumping status. We had 250 people that went bungee jumping just today, and 250 people that did not. And of the 250 jumpers, 150 reported drinking Mountain Dew. They did the Dew that day. And then of the 250 non-jumpers, only 50 reported drinking Mountain Dew. Most of the non-jumpers also reported a preference for warm milk. Interesting. Could be an ancillary finding. Could help us to generate some hypotheses. So, which of the following statements would you consider to be true here? Jumpers and non-jumpers should be matched for beverage consumption. Absolute and relative risk of bungee jumping can be determined from the study. This is a cohort study. The study can be used to calculate an odds ratio, or unanticipated outcomes can be assessed in this study. What do we think? I know these sound silly, but it makes it more interesting for me to talk about, and so otherwise I'll go crazy trying to talk about boring stuff all the time. I think D from Aaron. Well, let us see. See some more D's. And absolutely, this is D here. So remember, so let's kind of go through each point here. So actually, let's start with C first. So like, why is this not a cohort study? Anyone know? So again, how were people arranged in the study? How did you define the groups? Well, it's based on whether they went bungee jumping or they didn't. That's sort of our outcome right there. We already know whether they went jumping or not. And so at that point there, we can consider people that were jumpers are cases, and then people that weren't are controls in that case. Now, normally in case control studies, you oftentimes have multiple controls for every case, but in this case here, or in this situation here, we just had equal numbers in each group. So based off of that, why wouldn't you want to match them for beverage consumption? Well, because we want to find out, like, was there a relationship between, an association between drinking Mountain Dew and bungee jumping, right? Do they leave a more extreme lifestyle because they did the Dew, right? That's what we're trying to figure out. So in that point there, drinking Mountain Dew or not is the risk factor. Okay, if we match only Mountain Dew drinkers with other Mountain Dew drinkers, then at that point, they are too closely matched. You couldn't tell a difference between them because you're only comparing people who drank Mountain Dew with other people that did as well. So it doesn't really work. So that's a case where you can sometimes overmatch people in these case control studies. Now, what sort of things would you want to try and match them on? Any ideas? Age could be a good one, right? So that way you only have similarly aged people who are jumping together. What do we say? It was were they teens? Yeah, teenagers. So maybe you have like your tweeners, they're being compared with one another versus like your 17, 18-year-olds. Sex would be an important one, right? So you compare, males with males and females with females, etc. Mental health could be another one, right? Someone's like, don't even worry about the bungee cord, and they're like, no, you need the bungee cord. Okay, well, you match them with other people maybe who have depression as well. So absolutely. So I think those are all could be decent things to consider matching them on among a myriad number of other things. Well, again, remember we said we don't want to match them on consumption of Mountain Dew because that's the risk factor we're actually interested in. So again, that wouldn't really tell us what we want to know at that point. So in that case there, because we're doing a case control study, remember you can not really do, you can't determine absolute and relative risk. The way you would do that is if you had done it the other way around and said, okay, I'm going to take 500 teens, I'm going to give them 250 of them Mountain Dew, 250 of them not, and then figure out what percentage of each of them are going to go bungee jumping, right? So in that case there, you can determine risk. In this case here, we're looking at risk factors, and so that's odd ratios of what we're going to use for those types of studies. So that's ruled out. And then remember, with case control studies, you can look for a variety of risk factors. You're stuck with the one outcome. On the other hand, if you do a cohort study, you can have as many outcomes as you want, but you're basing off of one risk factor typically, right? At least if you're doing two groups. Hopefully that makes sense. All right. So the odds ratio calculated from the study would give us the odds of drinking among jumpers to drinking among non-jumpers, drinking among non-jumpers to drinking among jumpers, drinking Mountain Dew to jumping, jumping among drinkers to drinking among jumpers. That's confusing. Or non-jumping among drinkers to non-drinking among jumpers. What's the actual comparison we're making here? Let's not bring Jesus Cristo into this, okay, guys? The tongue twister, yes, perhaps. So remember, this is basically where we're looking at our cases, or the cases of people that went jumping, the risk of them having drunk Mountain Dew compared to those who did not go jumping, right? So again, we're seeing what is the risk of them, basically the odds of them having this risk factor in their history versus those that not go jumping, okay? And again, this is analogous to any sort of case control study, whether you're looking at actual important things like medicine topics versus something as silly as this, right? Okay. So the results of the study indicate, so we see, let's say we find a statistically significant difference between the groups here. It would say that bungee jumping and beverage choice are associated. Bungee jumping and beverage choice are causally related. Bungee jumping influences a person's choice of beverage. A choice of beverage influences a person's tendency to bungee jump, or there's no association between warm milk and bungee jumping. What do we think? Think A? It's very good. So again, this goes back to that causal associations. Goes back to again, correlation does not equal causation, right? It's always the kind of the golden rule there. So in this case here, you can see that there's an association, but you can't really take any other things away from that, right? So certainly you couldn't say that they're causally related. You can just say, hey, there happens to be an association here. It looks like people who bungee jump tend to be more likely to drink Mountain Dew here. You couldn't say bungee jumping influences a person's choice of beverage, right? Because again, you can't necessarily take that away. You'd have to design another study to do that. Choice of beverage influences a person's tendency to bungee jump. Again, you need to do that based off of like a cohort study. You'd actually have to like have people drink Mountain Dew versus not, and then go and see how many of them actually go bungee jumping at that point. And then, as we mentioned, we're only looking at the Mountain Dew association there, so we couldn't necessarily warm milk had anything to do with it. Again, sometimes you find those little odd pieces of info in the study, and you can then go on and do further studies off of that. But again, sometimes you find these little oddities and say, okay, that's interesting, but then you move on from it, right? Okay, very good. Let's see here. So let's say we do another hypothetical study here. We randomly assign subjects to 2 years of PA school, this is our intervention, versus 2 years in another type of graduate school, which is our control, and we test for evidence of burnout. That's our outcome here. So some of you may find this near and dear to your hearts. Of the 100 subjects assigned to each condition, you find evidence of burnout in 72 of the PA school group and 43 in the control group. Okay, does that sound pretty close to real life? Likely so, yes. So in this case here, an appropriate measure of association in this study would be incidence density, power, likelihood ratio, odds ratio, or risk ratio. What would be the best way to detect a measure of association here? E. Remember, we assigned people either go to PA school or another type of graduate school, and we looked for an outcome. Okay. In that case there, we're able to use risk ratios, right? If you had done this the other way around, if you'd said, look, here are these people that have burnout, versus those that don't. And then you want to look backwards to see, well, which type of graduate school do they go to? Were they doing a doctor's in healthcare science? Were they doing PA? Were they doing something else? What were the risk factors there in terms of, were they more prevalent people with burnout versus not? So that would be the case where we can use the odds ratio, right? Again, power is only telling us our ability to be able to detect a difference. It doesn't really give us any ideas about association there. Incidence density is really just descriptive. It just really kind of counts the number of things that are there. It doesn't tell us an association necessarily, but because we're doing a cohort study like this, a risk ratio is absolutely able to be calculated. And the reason why it's able to be calculated is because we know the denominator. We know the number of people that were at risk. And in this case here is 100 people in each group. Because when you're doing like a case control study, you don't know the total number of people who are at risk for the disease state. You just have a number of people with the disease state. You can't do risk ratios. That's why you're stuck with odds ratios. In this case here, we can do a risk ratio quite easily to tell us, okay, was there an absolute difference in risk between the two? Was there a relative difference in risk? And we can get that information, right? Okay. So let's say we wish to determine the proportion of myocardial infarction. Let's see. So we can do risk ratio because we know the denominator. Yes, when it's a defined denominator. So if you have, like, again, I put 100 people in each group, then yes, because I know in total the number of people who are at risk of burnout in each of those groups, and that was 100 because the researchers had set that up. Yep. Okay, so let's say we're looking at, we want to see the proportion of MIs that are fatal within 24 hours of their occurrence. You decide to examine the records of all local EDs and physicians' offices. You then calculate the proportion of the reported MIs that resulted in death 24 hours or less after the patient was initially seen. You briefly discuss your plan with a friendly neighborhood biostatistician who immediately points out that your study is particularly subject to which of the following forms of bias: the late look bias, a lead time bias, measurement bias, observer bias, or selection bias. What do we think? A. Let's find out. Right. So why would this be a late look bias? Why do we think that? So remember, do people who develop an MI, are every one of those people seen at a physician's office or an ED? Do some people die in their home? For sure. Some people have like a silent MI and they don't ever seek care and they live, right? So you could be missing people that either died within that 24-hour period, or you're missing people who developed, maybe a subclinical MI that, kind of just lived past that 24 hours. So that's the reason why you could be missing that, why you'd consider it to be a late look sort of bias, and particularly with the people who died early before they were even seen there. So you again have a bit of a skewed bit of information because that bias was introduced there, right? In terms of something like measurement bias, when could that be introduced? Any ideas? Yeah, that could be one, Matt, where, like, for instance, if the lab reported, or if maybe even if like your definitions of MI were different, for instance, if you were doing something where like different levels of troponins were considered to be positive or negative, for instance, things like that could be an issue of measurement bias there, right? Or if the lab again is reporting it differently. Jonathan's asking, how can you distinguish that a cohort trial was done or not? Very good. Can anyone help us out? How could we distinguish it's a cohort trial? So remember, if we are organizing our groups based off of presence to a risk factor, again, just like Matt said, we have a defined denominator. So again, a group of people who are at risk for developing an outcome, that's a cohort. That's the definition of a cohort, basically. So if we are organizing it based off presence or absence of a risk factor and then following them for an outcome, you can assume it's a cohort study, right? If it's something where you're starting with the outcome and then you're looking backwards for the risk factors, then that's going to be a case control study, right? Cohorts go risk to disease, case controls go the other way. That's absolutely true there, right? But again, when you're doing a cohort, I'm defining the cohort. Like you guys are all a cohort. There's 62 of you in your cohort at risk for, say, acing the EpiBio exam. I know what my risk is, or I know what my total number of people at risk is, and it's 62, right? And I know the numerator is going to be 62 as well, right? I'm very confident in all of you, but you kind of get the point there. So again, if I'm defining the group, then that's the cohort based off of the presence to the risk factor. How about like observer bias? What would introduce observer bias? What do we think? So again, who is making the determination of, okay, so a distorted observation, how would you define that? Yeah, there you go. So if someone could interpret the EKG differently, so someone, not everyone has an MI comes in with like the tombstone looking ST elevations, right? So because of that, you would, there is a chance that people could read EKGs differently. Or if you just relied like on the machine reading, like that would obviously be more of a formulaic measurement bias when you go off something like that. So those are issues. Selection bias tends to be more so if like patients are picking like what group they go into. Things like that. So those are all things you want to consider in terms of like defining different types of bias. Okay. Let's see here. When talking about disease transmission, if we're looking at malaria and the mosquito involved in that transmission, would we consider that to be an animal reservoir, commensal to the transmission of malaria, parasite, a surrogate host, or a vector? Would be the animal reservoir for the disease. Oh, you learned this in micro. Well, good job. That's fantastic. See, there's some crossover between stuff. I guess we could be considered the animal reservoir. Aren't we all animals in the end? Yeah, it's going to be more of a vector, right? Very good. Like when I'm trying to like train my kids to do something, behavior-wise, and my wife is like, well, don't talk to them like they're dogs. And I was like, we're all animals, right? We all respond to conditioning. So I'm going to start ringing this bell, and when they start slobbering, then I'll get them food. Like, it's just how it goes. Jeez. I don't do that to my kids. Okay, so let's say we have data being reported for cases of a relatively mild disease such as chickenpox, so something that is endemic to a degree. Could you generally characterize that data and how it's reported as being highly accurate because of active surveillance, useful for establishing prevalence but not incidence, valuable for detecting changes in the pattern of disease, valueless because mild diseases are underreported, or valueless because most patients with mild disease do not present for medical care? What do we think? I think C. And couple C. So I think I'm going to go with that one for sure, right? So again, to have active surveillance, someone actually has to be like calling hospitals, calling physicians' offices, calling all these places here to see who actually has the disease. We don't do that for things that are relatively mild, things that are not happening in epidemic sort of levels, or so in that case there would not be active surveillance. It would just be kind of what gets reported out through normal automatic reporting mechanisms. Now it's useful for establishing prevalence but not incidence. Why is that the case? Why is that not true? What do we think? If you think about it, like prevalence of chickenpox isn't all that high at any given time because it does resolve on its own fairly quickly in the grand scheme of things. You would be able to detect incident cases a little bit easier. Yeah, it would actually be the other way around in that case there. Because again, if you count the total number of people with chickenpox at any given time, it would probably not be very high, but we can at least get the idea of new cases. Now it is valuable because again, you can look at the pattern of disease. If all of a sudden it was like spiking up 2 times what would normally be reported, that's still a trend that's concerning, and you want to investigate that further versus, if it's around the normal levels, then you say, okay, well, nothing's really going on with it. Very good. Okay, so let's say the following deaths are reported for a population of 2,807 men aged 35 to 68. They found 4 deaths in non-smokers, 11 deaths in men smoking 1/2 pack of cigarettes per day, 18 deaths in men smoking 1/2 to 1 pack per day, and then 43 deaths in men smoking more than 1 pack per day. So from this, what could we conclude? Smoking increases mortality. We say the relationship between mortality rates and smoking is linear. There is a dose-response relationship between smoking and death. To interpret the data, the age at death is required for each case, or to interpret the data, the information must be expressed as rates for each risk group. What do we think? E. Let us find out. Actually, is E. So why couldn't you say that smoking increases mortality just based off this information? Only men. Don't know the number in each group. Little power. Right, so we haven't really done any statistical tests necessarily to say that there is any true difference here. We also don't know how many people are in each of these groups, right? So because of that, we don't really have a good definition for our group. So maybe the percentages are similar in each one. But also the other thing to consider too, do you think more people smoke like a half pack to say a pack per day than the total number of people who smoke, say more than a pack per day? Probably at those higher dosing ranges, you find fewer and fewer people. So we know smoking increases mortality, but in this case here, we can't really tell off the information without having better definitions of our groups, right? We also don't need to know like the age at death at all in order to accomplish this. If you had age groups, that may be able to be helpful, but you don't need to know the exact age. But again, when you have rates for each of the risk groups, that really helps us out because then that's equating the number of people who had that death over that mid-period population, right? So again, that's helping us with that definition of the numerator and the denominator, and then we can make heads and tails of the information there. So that's why, in order to interpret that, that's what we need basically. There probably is a dose response relationship, but again, without having that information, we don't really know. Okay. Let's see. Which of the following examples might represent a retrospective cohort study? Because again, we mostly think about cohort studies being prospective, but they can be retrospective as well. Let's see. Cases of lung cancer assessed for prior exposures. Subjects randomly assigned to active varicella vaccine versus placebo, then followed for chickenpox. Subjects with current angina followed for the development of myocardial infarction. Subjects with prior radiation exposure followed for the development of lymphoproliferative cancers, or subjects with skin cancer assessed for lifelong cumulative sun exposure. I think D. Very good. Right, so in this case here, the timing is what's really important. So for instance, if you look at subjects assigned to receive active varicella versus placebo, that would be more like a randomized controlled trial, which again, your cohorts are again where patients get randomized to. So you can kind of think about cohort studies and randomized controlled trials similarly in terms of how they're designed. It's just a matter of how do you define who your control group is versus your experimental group in that case there, right? So that's a little bit different in that case. And obviously there's no randomization in a cohort study. If you're looking at cases of lung cancer assessed for prior exposures, what would that be? You're taking a group of people that have the disease in question and looking backwards to see what type of risk factors they have. Yeah, it'd be case control at that point there. Subjects with current angina followed by development of MI, that'd be more like a prospective case control study, more like what we've kind of been talking about typically. And then subjects with skin cancer, again, if you're starting with the outcome already, then you're not dealing with a cohort study, right? Whether prospective or retrospective. But because of the case here, they have prior radiation exposure, and then you're looking for that development of lymphoproliferative cancers. Because everything's in the past, you can consider that to be a retrospective cohort study. Like the one I talk about with my coral snake study that I did, that was a retrospective cohort study where basically people were divvied up based on their risk factor of getting coral snake antivenom early or not, and then everything was from the past. Everything was, we're not looking at active cases essentially. Okay. Sorry for all the screaming in the background. Is what it is. Let's say we have a physician's health study. This is actually a really large study. It was done years ago. It was a randomized, double-blind, placebo-controlled trial that was designed to test the effects of aspirin and beta-carotene on cardiovascular disease and cancer. Participants in the trial consisted of approximately 22,000 male physicians who lived in the U.S. that were 40 to 75 years old. Randomization of participants in the study was performed to help achieve which of the following? But why do we do that randomization? Does it eliminate bias? Does it help with external validity, internal validity, prevention of confounding, or statistical significance? C. Anyone else? So it's actually with prevention of confounding. To some degree, the randomization process helps out with that, because if you have individuals, say for instance, who some of those physicians were maybe smokers versus some were not, by them being randomized, that helps to make sure that confounding, because they should have similar rates of smoking between the groups at that point if everything is truly randomized. Internal validity has more to do with the study design in terms of like how they're being broken up into their different groups, and then what kind of statistical analysis you're doing on that. What's external validity like? What does that mean? Right. So as a study like this, does it seem particularly generalizable to anyone? This was just done in male physicians who were in the U.S. They're 40 to 75 years of age, right? So probably not, right? Because again, having that qualifier of having just males means it doesn't necessarily apply to females. Having that qualifier that's just physicians, that implies that maybe they are more likely to have healthful habits. Perhaps not always the case, but there are certain biases that can be introduced with that. Even if you did randomize, you couldn't eliminate all types of bias. So in that case, there, I would probably not consider this to be very generalizable, and thus the external validity is not great for this type of study here, right? And again, randomization doesn't really have anything to do with statistical significance. More so, that has to do with the power of the study. And having a study with 22,000 people is pretty good. You probably have enough power to look for something there. All right. And again, you can read through all this stuff and kind of get the same points that we're hitting on here. Let's say we have a new disease that's being reported in the U.S. called maple syrupitis, and it's originating from up north, coming down from Canada. It's been reported to have caused 5 deaths so far. Your hospital initiates screening for all patients reporting to the ED to see if they have traveled to Canada in the past 6 weeks. What type of surveillance is this? Anyone know? Any ideas? About active versus passive. Any ideas now? Right. If you're actively asking every single patient that comes in, have you been to Canada in the past 6 weeks? Then that would be a form of active surveillance, right? If you had the CDC calling up saying, "Hey, have you guys been checking these numbers? Have you been asking these people? Have they traveled here?" Or the Department of Health, whoever, it's active surveillance, right? Now, what phenomena might do you think these first few deaths actually represent? We talked about phenomenon there. It's like a first few like really high profile deaths that really get everyone really kind of perks their interest a little bit, or it kind of gets them really more likely to screen for this sort of thing in other patients. Remember, we call that the ice. Yeah, there you go. The iceberg phenomenon, if you recall. Just like remember when we back in the I don't know, I think approximately 50 years ago, back in March of 2020, we had just like that one case. Like one case was being reported, whenever it was in February, and that was there were likely more people who were asymptomatic at that time that had COVID. Right. It wasn't until we get better screening procedures, better means of testing people and things like that before we realize the full how many people actually had the disease in question. So that's why the first few deaths of something usually kind of perk everyone's ears up and think, okay, I should probably be looking for this, and that can then people in the lay people may think now they have the disease in question. They may go back to the hospital for further evaluation, things like that. But that's part of that iceberg phenomenon they see there. Okay, so any questions on that so far? Anything at all? Let's see. Someone's wanted to clarify, is mid-period population the amount of people halfway through a given study time period? Absolutely. So if you were to look at, if you had 100 people at the very start of a study and then you had, 0 at the end, that mid-period population is 50. It's roughly the average number of people at risk for a given disease state, right? And again, how that number shifts based on did that decrease happen very early or did it happen very late? Will give you an idea of different forces of mortality. So that's why that's really important when you're looking at rates or using that mid-period population. Okay. So I told you I was going to do something very daring, very very interesting. I wanted to show you guys the study that I Googled while writing the test. But I said, I'm going to look at this study. I'm going to pull something to introduce a test question on the exam. Okay. So you guys can look this up. You can find it. You can get it through the NOVA library if you like. Now, do I want you to actually read through this whole study? No, but I'm going to look at is the interpretation of the study itself, making sure that you guys can look at things like odds ratios and whatnot to actually be able to interpret them. So this is not going to take real long because I'm not doing a whole journal club on this. But what is this study? They're looking for some predictive values of certain clinical symptoms in patients who tested positive for SARS-CoV-2 and those that didn't. And this is in healthcare workers in the Netherlands. Okay, the Netherlands portion is not really important here. But again, look, they have a total number of healthcare workers that developed some sort of mild illness symptoms, is how they defined it, I think. You know, they were coming down with a cold, they had a fever, they had something, and they wanted to go ahead and do a SARS-CoV-2 check on them, right, to do a test on it. You guys can hopefully see it okay. And actually, I'll probably post this afterwards, so I don't think about it. So if you can't find it, I'll go ahead and post it up. But again, they have 803 people here. They have 90 that were SARS-CoV-2 positive, 713 that were not. And they wanted to do is try to figure out what symptoms were present in these people and how did that differ amongst those that were positive versus those that were not. So this is the table I really want you to focus on here, is being able to look at these things. So remember, the type of study this is they already have the healthcare workers. They already know if they're positive for SARS-CoV-2 or not. Right, so that's the outcome, and then they want to look backwards to see which risk factors they had. So in this case here, it's a case control type of study, and again, look at their reporting odds ratios. They're not doing risk ratios or relative risk or absolute risk reduction or anything like that. So you have your odds ratios and then the p-values. Okay, I'm not going to give you p-values on the test. You're going to have to be able to interpret it off the odds ratios, but we already know how to do that, right? Because again, if you know it's an odds ratio, you know if it includes what? 1, it's not going to be significant, right? So some of the things I want you to look at, some of the things that are important, because if you were to try to design a screening program for some of these patients, you want to know what kind of symptoms you're looking for, right? You want to know the ones that are really specific to something like COVID-19 versus things that are not really all that associated with it, right? So this is why odds ratios are really important. This helps us out with the sort of the predictive ability for these tests to help us determine who has the disease and who doesn't, right? So as an example, let's look at something that wasn't really very specific to having COVID-19, right? So let's look at something like runny nose. Like if you look at runny nose here, what do you notice? Okay, so 26.7% of people had COVID had it versus 32.4%, right? Notice it's going to be, if anything, it looks like people who had COVID-19 were less likely to have a runny nose than those that were negative, right? Because it's a less than 1 on that odds ratio. When you look at that though, but notice it includes 1, so it is not statistically significant. So this case here, if you were trying to design a screening program for COVID-19, would you include a runny nose in that definition there? Probably not, because I couldn't tell the difference if someone had COVID-19 or not just based off the runny nose, because there's no statistical association here, right? So interesting things you can note off of this sort of stuff here. Now, how about something like anosmia, right? Or something else that is like highly specific. Actually, anosmia is like one of those things they always include in there because it's very kind of particular. What do you notice about the odds ratio here? What kind of takeaway could you take from that number 23? Well, it means that people that ended up testing positive for COVID-19 were 23 times higher. Their odds of having anosmia were 23 times higher than people who end up being COVID-19 negative, right? So would you include that in your list of things you're screening for in the population? Absolutely, right? Because that is highly, highly associated with that symptom, highly associated with that particular disease state. You'd want to include that. And that makes sense if you look at the odds ratios, look at the confidence interval, it has nowhere near 1, even though it is quite wide, right? And remember, if you have a wide confidence interval, it means that there's a lot of variability there. So it's maybe not be the perfect test. You don't want to necessarily hang your hat just on one symptom, but it helps, right? It helps to know that that's strongly associated with that particular disease state. And so again, in that case there, you can see it's a p-value of less than 1. So does that kind of make sense? Being able to look at these sorts of things, be able to say, okay, well, what was more present in people who had the disease versus not? What kind of things would I want to be able to take away from this sort of thing? What kind of associations can I make? what sort of conclusions can I take away from something like this. The test question is going to have something to do with a table similar to this. I will give you the information, I'll give you the numbers, and then I will have some conclusions that may or may not be true, and you got to figure out which one is the right one. That makes sense. So why am I telling you this? Because I'm feeling nice, not in particular, but I wanted you to feel prepared. I wanted you to know that, okay, well, am I able to look at this information and take something away from it? Because I think this is an important skill when you're evaluating the literature that's out there. So if you thought this was dumb, put it on my eval. I won't do it again for the next time, but at least I thought it was an interesting way to write a test question, which I'd not tried before. So again, you don't know which symptoms I'm going to put on there. Could be any of them, but some of them might be on there. So anyway, so that's pretty much it for me. Do you all have any questions? So someone's saying, so would anosmia be specific but not sensitive? So we could figure that out. You could actually put it into that 2x2 table, because we know who has the disease and who doesn't, right? So you could do it in people who actually have the disease or were positive for that versus people that were not. And then you could do the same thing for people that did not have the disease. And so you could calculate the sensitivity and specificity. I didn't do that, but again, remember that relationship where you want highly sensitive tests early on. So that way, even if you have a lot of false positives, so something, for instance, like extreme tiredness was definitely associated with something like COVID-19, but it's probably gonna have a lot of false positives because a lot of people that are sick feel tired, right? It's a subjective symptom. So this is one of those things where it could be, probably sensitive, but not very specific in that case there, versus something like anosmia is probably gonna be much more on the specific side of things, if I had to guess, but I haven't done the numbers myself. But they do studies like this in order to come up with positive predictive values and things like that. So when they come up with a screening test, they can say, okay, these are the symptoms we're looking for. These are the ones we don't really care about. And you can do that too with things like, how do you determine someone who has a PE, right? How do you determine someone's having a stroke? You could do different things like that to come up with similar results. So anyway, so that's it. I'll post this up for you guys on the Canvas site underneath the video that I'll post up for this. And if you guys have any questions in the meantime, feel free to shoot me an email. Again, the sooner you get it in, the sooner, more likely I am to answer it. Otherwise, I will see you all, I guess probably the next sim, hopefully if I can make it to that, or the next lab or whatever. But otherwise, I'll see you all for Farm 2. Have a good day.